Good morning and welcome. We are halfway through the year. Does it seem like it's gone by so fast? Very July. Let's start with the roll call. We'll start in the room and then we'll head to the phone. We'll start with Caroline.
Caroline, North Central ACH.
Mariah, North Central ACH.
Heather Smith, North Central ACH.
Roger Charpentier, I'm part of the technical consulting team.
Blake Edwards, Columbia Valley Community Health.
Holly Sponek, Children's Home Society. Mia Davis, Coordinated Care. Brittany Ward, AmeriGroup.
Tessa Timmons, Confluence Health.
Craig Mott, Confluence Health.
Jorge Rivera, Molina Healthcare.
Pat Sanger, Cascade Medical.
Deb Miller, Action Health Partners.
Melody White, Family Health Centers.
Lynn Evans, Parlight, NCACH.
Paige Bartholomew, Action Health Partners.
Amy Gleason, NCACH.
Chris Washerman, North Central ACH.
And our fearless glue behind me is Teresa. Holds us all together. And I'm Wendy Bresney, North Central ACH. Let's go to the phone. Who do we have on the phone?
Lisa Apple, Panacan Behavioral Health Care.
Good morning, Lisa.
Kendra Palomares, Catholic Charities.
Loretta Stover, the Center for Alcohol and Drug Treatment.
Amy Hilliard, Catholic Charities.
Shoshana Palmentier, Cooley Medical Center.
From CBHA, Dulcie Field and Haley Middleton.
Kathleen Rhymes from the consulting team.
Moses Lake Community Health, are you guys out there? Okay, I see Heather Massart from Moses Lake Community Health. I think she doesn't have a microphone. And Dawn from Parkview Medical Group. No, anyone at the top? John McReynolds.
North Valley.
North Valley? Welcome, John.
I think that's Rebecca.
Rebecca Corson from Mid Valley. All right. Can you repeat that?
I'm here.
Welcome. All right. You have the agenda. You have the agenda and minutes in front of you. We'll start with the agenda. Can I have a motion to approve the agenda?
Nobody wants to. I'll move to approve the agenda, Wendy.
Thanks, Deb.
You're
You have a
welcome.
second?
I'll second it.
Melody seconds. All in favor?
Aye.
All opposed? Sorry, I did not give a chance for those online. Okay, you have the minutes from last month. Also, I need a motion to approve those after you have a chance to look over them. And for those online, feel free to chat in or turn your mics on.
I'll move to approve.
Thank you, Jorge. Have a second? Thank you, Blake. All in favor? All opposed? All right. Let's move on to announcements. Are you dancing side? No, I'm the dancing side. Reminder for those in the room, microphone, I do have my Fearless sign to use your microphones. Go ahead and turn them off now if you're not speaking, because the shuffling of the papers becomes loud for those on the phone. Okay. We did want to bring to your attention that the Healthcare Authority will be rolling out a few assessments all at the same time or sequentially over the next few months. The first one is the ACH. If you remember in the MOUs, for those of you who looked at the MOUs, there's some opioid questions and some behavioral health integration questions that the Healthcare Authority has asked us to report on in our pay for reporting. So there was a survey that went out last week, I believe, and I have that's completed. Children's Home Society, Samaritan, Parkview, Catholic Charities, and Family Health Centers has all completed it. So I've tried to put the leads, who was my primary contact, as the person on there. So if you haven't received it, let me know. We'll find out who the contact person is. We do ask that every organization complete that. That is part of our pay for reporting, and we get credit for that, which means we get money for it. So we do ask everyone to look to make sure that they've completed it.
Just so you know, an email came from me, so if you're looking for it in your inbox, it should be from myself, John Chapman, for those on the phone. I also resent it this morning, so you should have it in your inbox this morning.
For those of you on the phone who may not have heard John, the email came from John. He sent it last week. He resent it this morning. So if you didn't get it or you're not sure who your contact is, just reach out to either me or John, and we'll let you know. There's a value-based payment survey. If you may remember doing it last year, that came out this morning from Healthcare Authority. They're sending it to all the payers, all the providers, and all the MCOs. If you remember a few months ago, JD Fisher did a presentation on that. And if you want to look back, it's actually on our website. We clipped out that portion and added it if you're interested in what he said. It came out July 1st. It closes August 30th. Again, it's a way for the Healthcare Authority to understand where we are as a region. Last year, we had the best participation. I think we had all but 2 organizations participate that I'm aware of. There's a question on there, just sometimes it's not evident what we're doing because we're not wrapped up in verbiage or processes. We want things to flow naturally. So there's questions about patient-centered medical home on there, and the change plan was built around patient-centered medical home, and I'll go through that in a minute. That, as well as the BRE Collaborative for the behavioral health integration. There's some questions on the 6 levels, SAMHSA's 6 levels of collaboration integration, and if you're working on the BRE Collaborative's recommendations. Those processes are actually built into the change plan itself. It doesn't spelled out. It's not spelled out patient-centered medical home, and it's not spelled out BRE Collaborative, but I did want you to be aware of that. And the last question on the survey asked if they can send the results to the ACH. Last year, all of you did. I would ask that you do it again. Part of that is that we can look at as a region. We don't share those out beyond us as individuals. We'll share out an aggregate or have the Healthcare Authority come and present like they did last year and share aggregated results. The next survey there's 2 assessments or evaluations that are coming out. One's from the independent assessor, one's from the independent external evaluator. Those are coming out soon. The IA is the September 16th through the October 18th, and the IE is sometime in the fall. There's some overlapping questions through all 3 of those, the VBP, the IA, and the IEE. You will notice. We have brought it to Healthcare Authority's attention, but because they're assessing it in different ways and because of the way they do their reporting and because they're independent assessors and evaluators, they all have to ask their own questions. So just be aware of that. VBP will overlap all 3 of this assessments, and I'm trying to think, what was the overlap between IA and IEE? I spaced that off the top of my head, but there is some overlap. You may be contacted. I don't know who they'll contact. As far as they're not going to contact everyone in our ACH, but they will be contacting different organizations. And finally, we are doing MIHAS again in the MOU. If you recall, we have to do MIHAP assessment for all organizations. We have to do it at the site level according to the Healthcare Authority. Mariah and Heather are reaching out. They've already done some of them. If you haven't heard from them, they will be reaching out to get those scheduled sometime in the next, dare I say, 6 months, because there's so many sites. So they will do it as they're able to. Any questions on any of those that I just talked about? Anyone from on the phone have a question?
Will the paying for the value survey, does that go to our CEO or who does that get directed?
The VBP?
No, the pay for value survey? What should have gone up today?
Did it go to?
Usually it's the CFO.
Usually it's the CFO or CEO. And when we've reached out to partners in the past, it has normally been those contacts. So we may, over the course of the next 2 months, do some individual reach out as an ACH, because we're also, it's a requirement for us to continue to vote the survey. But we'll keep you informed by providing updates at the next meeting.
John said that the VBP survey that went out today went to the CFOs or CEOs. If you haven't responded, ACH lets us know, and we may do some individual reaching out to you. Any other questions? Okay. An opportunity I wanted to share with you, it is in your packet. As you are forming your QI groups or working your QI groups, and you're bringing providers who are diplomats with the American Board of Family Medicine into your change plan activities, that does qualify for some of their performance improvement activity that they have to do for their boards. They have to do one activity in this area every 3 years. So I would share, it's in your packet, this document. It kind of walks through, it is the change plan. Like, all the areas are in your change plans. There's aim statements, there's metrics. Even though you're doing it as an organization or as your QI, they can get, as long as they're involved in it, and as long as they're following their individual metric as them to show that they're doing improvement, they can get credit for it. So it's an incentive for providers to participate in some of these QI. At the very bottom, I added to the PDF a contact information for Ann Williamson. She is the individual at ABFM that I spoke with. Her direct contact is there, so feel free to reach out to her if you have any questions. And she said that I could pass that on to you, her actual contact information, so you don't have to go through the switchboard. She's very helpful and will walk you through the steps if you have questions. Are there any updates from any of our partners, from the learning community, from the MCOs, from the CBOs? I just want to make sure that we cover everyone, because you're all a part of this WPCC. I don't think I've made that explicit previously. Yes? Go ahead and turn your mic on. Yep.
It's on.
So for those on the phone, I'm Gail Goodwin with Grant Integrated Services. We came in a little late, but we do have with us today Dell Anderson, who is our new Director of Clinical Services. Our long-term Director of Clinical Services, Lisa Cordova, is retiring. So yes, shocking. She's very young. It's kind of annoying.
You jealous?
I am, yes, you can tell. So we are very happy to have Dell on board. Today is day one. Dell. And if you want to just give a brief about you, where you came from.
Yeah, so we moved to Moses Lake, my family and I, about a year ago. I've been the Director of Behavioral Health over at Moses Lake Community Health, and just saw this as a unique and good opportunity. I was the Director of Behavioral Health for the last 8 years at Tri-Cities Community Health over in Pasco. And so familiar with the state and getting more familiar with this region.
Excellent. Well, feel free to reach out if you have any questions.
Great.
as we move forward. Any other announcements?
Quick one, Carol Deedy, Chief Operations Officer.
Microphone.
Carol Deedy, who's been our Chief Operations Officer and been with CVCH 30 years, retires and walks out at 11:45 this morning. There'll be a line of all the employees on both sides. I won't get to be there, but this is her last day.
Well, we wish her well. Who's taking your spot?
Manuel Navarro. Yeah. As of tomorrow.
It's 11:46. Anyone on the phone have any updates they want to share? Okay. Yes.
I think we should probably announce that it's Dr. Colby's last day today as well.
Mass exodus.
I know, yeah. So his wife got a job and he's going to be supportive of her move to Michigan. So he'll be moving to Michigan and I think they leave tomorrow.
Wow.
So today is his last day too.
Well, Miss, we announced that I thought he would be gone by now, or I was thinking he would be gone by now, but again, he's been a powerful voice at the table.
This is Courtney Ward with Mayor Group. For those who haven't heard, Anthem has acquired Beacon Health Options, so they will now be a part of the Anthem umbrella of services. Lots more information to come, but that was announced weeks ago, last week, somewhere around there.
Thank you.
Holly Zvonek, Children's Home Society. So our CEO has retired and we have a brand new CEO. And he will be out visiting our site tomorrow and the following day. So we're looking forward to some transitions. What we're hearing is that he likes change. So that'll be fun.
We have a change plan.
We do. So we are familiar with change.
We are familiar with change. Dare I ask?
This is Dr. Duck from Lake Chelan.
Yes.
And I just wanted to say hi, that we're on the call, and that our CEO is also retiring in September. And so our search is on for a new CEO out here as well.
Thank you. Yes. Who is interim, but yeah. This is the interim that was hired on and then decided to stay.
The interim who took the job as permanent, and now he's retiring.
September. Thank you.
Yep. Mm-hmm.
Anyone else? We're on a roll. Okay, let's move on to learning activities. We sent an email out last week. We are starting the Collective Medical webinar series. That is in your packet at the very end, is the syllabus for that. Caroline's worked very hard in putting this together, working side by side with Collective Medical. If you're interested, the dates are on there. The first two webinars are self-scheduled. If you're already signed up with Collective Medical, formerly known as Premanage and Eddy, you should be able to access those first two without any problems. If you have not signed on with them, let me know and we will connect you with the right person to get you signed up. So you go to a direct person, not a call center, to get that taken care of. If you're not signed on and you're interested in how this will be helpful for you, this would be a great webinar series because it's really going to introduce you to all the aspects of it. If you've been using it or just been using Eddy, again, this is also a great webinar series because it's really going to go in depth in how to optimize your use of it. So it's open to everyone. I will say they will have two individuals from Collective Medical on the third and fourth webinar to answer any questions you may have. So if you're thinking about it and you have questions, or if you're currently using, you have issues, or you want to know how to do something specific, let us know. We will send out a brief survey this week just to make sure we have some questions, and we'll forward those to the two individuals from Collective Medical so they can be prepared with answers. is going amazing. There's 132 participants, 19 teams, 12 organizations. It's quite the doozy. Keeping up with, finally got everyone registered, and really, it's really going well. So hopefully you're participating. And if you're not, those videos are posted on the website, and you can always view them. So we talk a lot about patient-centered medical home. So I just wanted to kind of back up a little bit with patient-centered medical home and kind of tie in our learning activities and what we're doing, where we're going. This is the way that Bodenheimer, in his paper of the 10 building blocks of high-performing primary care, published in 2014, kind of describes it. Engaged leadership, that's the series we've been doing with Roger during this meeting. The data-driven improvement, we did an introduction to quality improvement. We've done the QI affinity group, and I didn't put on here, we did the patient and family voice and quality improvement capacity building workshops. Empanelment, if you remember, we just recently finished up the empanelment sprint for the primary care. Team-based care is currently happening right now. So as you can see, we're really walking through the different aspects of this patient-centered medical home and showing step-by-step how to integrate that into your processes and workflows of your clinic. The patient-team partnership, again, is that patient family voice and quality improvement. And then the prompt access to care, we will be doing a webinar September 10th. We'll be sending out some more information on that, and maybe Roger will speak a little bit about it today. And then the final one, 6, 7, 8, and 9, because we'll continue with access. We'll start October 4th at that all-day kickoff here in Wenatchee. It is really going to be tying together. We've been doing some real foundational type learning activities like empanelment, sprint, team-based care, very foundational. Now we're going to put it all together as it pertains to disease process, depression, diabetes. What do all of these look like whenever you're working with a specific disease process, and looking at how to put it all together and develop those workflows around that. So that will start October 4th. Does that kind of make sense how is our method to our madness? I know we just keep throwing all these learning activities at you, but there is a method to it, and it is based on your feedback, both from surveys last year and the survey that we sent out earlier this year. Any questions? Okay, so I'm going to move on, God bless you, to WPCC peer sharing. I decided not to ask someone to present. Instead, I wanted to go over, we just recently finished up a motivational train the trainer. We had 14 participants. 2 were from Grant County, 6 were from Chelan Douglas, 3 were from Okanagan, and there were 3 NCACH staff participating in that. What that means is we now have 14 individuals trained in the ACH region to put on motivational interviewing workshops. So we don't have to wait for the consultants to train. They do not have to be 2-day. We can chunk them out over lunches or an hour and a half, 2-hour portions. So if you're interested, if you're in the WPCC learning community, you're one of the 17 organizations, reach out to your practice facilitator. They were both trained, and they can work with you to get those scheduled for your staff. If you're not in the WPCC and you're interested in these for community-based organizations, contact me, Kaylee from Action Health Partners was trained, as well as myself, and we can do some community trainings. For instance, Link Transit's interested in a motivational interviewing classes. And this was our way to build capacity within our region and then give back and build it up outside of the WPCC, as you know, like in the CHIs, in the TCDI work, in the opioid work group. So it's going to be open to anyone. Just contact one of us and let us know. Any questions on that? I will read this. I won't read. Melody, do you want to share some of your feedback from the training?
Sure.
Just throw you on the spot there. Not throwing her, I actually emailed her today.
No. It was really a really good experience for me personally.
Microphone.
Sorry. Let me assist you. Thank you. Yes, it was a great experience for me personally. I think that
I got a different set of advantages out of it than what I expected. I really thought that this was going to be something that I was going to go in and learn skills to teach somebody else that they were going to use, and it really turned into things that I believe that we're going to be able to utilize more at an organizational level at Family Health Centers, as opposed to just giving them MAs and nurses and providers those skills. It really brought home and kind of tied things together from the standpoint of what we've been concentrating on as far as social determinants of health and ACEs and trauma-informed care, and it was really the how to the why. And so that was really helpful. I thought it was a fantastic experience. It was exhausting because of the fact that it was such a different mindset for me personally, coming from the business side of medicine. It's not something that I've been ever trained on before. So it was teaching an old dog new tricks. That was a little tough for me, but the science behind it was really compelling. And so that other side of my brain, it made sense on what it was that we were embracing as an organization that really was going to bridge that gap between what we've wanted to do and have, made moderate successes with, and how to really tip the scales to be able to really get to that point of true community health. And the training was fantastic. I do feel like between Mariah and I will be able to do some really good work across the 7 organizations that will be starting with training. It'll be fun. So I was excited.
Hey, thanks, Melody. Paul Hadley from the center also, he sent me something. I'm not going to read the whole thing, but one thing he said is in behavioral health, they do choice theory. And he says, while choice theory is an explanation of how and why people behave, motivational interviewing is explanation of how and when people will change. So it's a way to get people to change on their own terms. So now I have a little question for you. Dr. Harold Stolovitz, in his book called Telling Ain't Training, reviews what researchers have discovered about the influences of successful application of what has been taught in a training to an actual work. So when you look at this, I just want to call out, and for those of you on the phone, please chat in. What influences successful application after a training? Is it the leader, meaning the employee's supervisor or manager, before, during, or after? Is it the actual trainee, or is it the trainer? So choose your top 3. What influences successful application of a training? The room, call out. What do you think is one of the top reasons? Top influences?
Could be cheating.
You may not answer. It's not that hard. Call out A, B, C, D, E, F, G, H, I. You think it's the leader before the trainer, before the training? Okay, anyone else? You think it's the leader after the training? Dawn from Parkview thinks it's H, the trainer during the training, F, second, the trainee after the training, or C, the leader after the training. Any other guesses? For sake of time, make sure I don't do this on a full agenda next time. It is actually the leader before the training, and how well they motivate and how much excitement, enthusiasm they show prior to the training. The second thing that influences is the trainer before the training, how well they reach out, the enthusiasm they show, as well as the preparation work that they do prior to the actual training. And the third is the leader after. And I bring this up in light of the motivational interviewing training, but also because of all the other trainings we're doing, the team-based care land, and then what happens October 4th. As leaders of the WPCC, when you send your employees to these trainings, you are really what influences the success of that training. So just kind of keep that in mind. On the last page, I believe it is, of your packet, there's a handout that has tips for leaders. Before the workshop, these are just some of the things that are on there, is communicate the importance. When you have the excitement and energy prior to, then you're going to give that to the trainee itself. Choose the right people to attend. Someone who's willing to learn a new skill. Obviously, someone who's disgruntled and doesn't want to learn may not be the right person because they're not going to go in with the right attitude. Give them opportunities to apply skills regularly. Make sure they have keen on learning new skills and they're respected by their peers. And then after the workshop, follow up with the different attendees about their experience, manage competing priorities to allow new skills to be adopted, provide timely, meaningful feedback. This is what you as a leader can do to make sure those individuals that you sent to the training, that you invested in, can be successful. And then sometimes we go to trainings, we come back, the trainer just kind of spews all their excitement and we're like, yeah, that's great, and we move on. We've all done it, I know, I'm sure. But how can you then, 12 weeks afterwards, when things and dust has settled and everyone's back in the grind, how can you follow up with your employee to make sure that they've integrated what they've learned into their new workflows? Make sure that they're still excited about what they learned. So just a few tips to kind of keep that moving and keep that enthusiasm going, because there's a lot of learning activities going on within the WPCC. Any questions? Go for it.
The other thing that I think was really helpful during that the trainer was towards the end, we talked about the fact that none of our organizations are necessarily going to be everybody ready for things like MI. And I think what has stuck in my head with what the trainers were helping us with is, as organizations, we can't necessarily mandate that people embrace a philosophy of culture. But what we can expect is for them to agree that they're not going to be MI averse. So even for the people who are not necessarily sold on the idea, that there are actually behavioral expectations you can do with administrators, providers, staff who aren't necessarily sold on it yet as the late adopters, and making sure that their expectation is very clear that if you don't want to get on board, you're at least not going to stop us from going forward in that spirit. So I thought that was really helpful for me personally as to how to kind of negotiate that with 200 people.
Right. Anything else? So we finally have a report out from Q1 reports. I've been working with Tina from CCMI. There is a lot of data that comes through. If you can imagine, 17 organizations reporting on 8 different sections. There's a lot of narrative, a lot of just data in general. And we're trying to figure out what is the best way to report out. And this is what we've come to as our first go round. We'll see how you guys really receive it and if this will meet your needs. This is a frequency chart of the progress to date status of the change plan section, the started, not started part of it. The progress status options are not started, planning, testing, limited implementation, fully implemented but with gaps, fully implemented, and spread. So for ease of reading, because there were so many different categories, the testing and 2 different stages of incomplete implementation were combined. Not started may include changes not started and changes not planned to start until a future date. And so note that there are not an even number of drivers between the change plan sections, so it makes sense that some areas look more dominant. So you can see chronic disease and behavioral health look like they have a lot of different things going on, whereas, say, social determinants of health, transitional care, community-based, they look like they have very few things going on. Observing lots of testing, that's that green line, and which is what we want to see at this time. And seeking to implement changing. Testing is good to see. It corresponds to learning and active improvement. So this is just a snapshot of the progress reported after the first quarter, and it's very similar to what we saw at the end of 2018, which we would expect because a lot of people were still working on change plans, and so really getting started in their implementation come January. Over time, hopefully corresponding to the visible improvements, we'll expect to see the green, I will say let me make sure, the purple and the pink, those bars, that's the implementation in the spread. Those, does that make sense to everyone where we're at? Something that we saw for all the capacity building workshops we've had and the empanelment sprints and the team-based, the learning and action networks, we've had 418 individuals participate. That's not individuals, unique individuals. That's in general just taking how many participated in each one. We'll try to break that out and to see how many unique, but it's a fairly good number. So we have a lot of great participation in all of our capacity building workshops, as well as our learning activities. And we've had 23 different organizations attend a NCACH-sponsored capacity building activity. We've opened the motivational interviewing and the QI up to non-WPCC partners, and they took advantage of that. So just some capacity building that we're doing within our region. I'm going to show you some improvement data. It was introduced last month. Remember that the charts that I'm going to show you, you can't draw conclusions from any of this data that I'll be showing you. These are just what we're going to start seeing in the future. The number of measures we have is about 20, the median from all the different organizations, and there's very few common measures amongst the organizations. We would like to see the WPCC gravitate to more common measures, because then we can start to compare organization to organization. We originally allowed people to choose what they were working on, which was the path of least resistance. It allowed people to build up their own infrastructure and figure out how they're going to do measurements and work on, but hopefully we'll be able to move to some more common measures. And those are the common measures we were talking about. We showed these at the last meeting: depression, MAT provider capacity, the opioid prescribing guidelines, child access to PCP are your top 5. And you can see you have 15 depression, so it's 15 out of 17 shows depression screen follow-up. MAT provider capacity is 10 out of the 17. So this data, again, is for learning and improvement. Can't draw conclusions. The solid line, horizontal line, is the median. But you can see our top 4 right there: the depression screen and follow-up, the MAT provider capacity, the opioid trainings. What this is showing is all of NCACH. For those in the learning community that have access to the portal, you'll be able to see these for your organization and for others as well. It's transparent. So if you know, say Grant Integrated wants to compare to Okanagan Behavioral Health because you're a like organization, you can look at Okanagan Behavioral Health and vice versa. Or you can look how you compare with the ACH as a whole. And there's a few more. Every quarter that will be updated. It is a live update. So as soon as you update, then within 15 minutes, the graph itself will actually update it too. So I'm not going to read all of these. These are in your packet, but key themes from the successes are strengthened improvement processes. There are more organized teams, processes, and systems, and increased collaboration and sharing across and within sites. We have better systems for gathering and processing information and data, and we have comprehensive care and services growing. So these are just the themes outlined. I'm not going to read through these because they are in your packet. You can go back and read, but these are some of the top ones that we pulled from each organization. Leave that up there for a little bit. Number 2 is more organized teams and processes. You can see how workflows are starting to change within the different clinics, within the different teams, and how things are doing, how they're reorganizing, defining roles. I'm sure working to the top of your license has become a statement that many have heard. Increased collaboration and sharing across and within sites. We are seeing a lot of this. We're linking organizations. I know one organization is implementing a new EHR, so they visited a second organization to see how they're doing. It's the same EHR. One organization is doing group visits. Another organization wants to see how they're doing group visits, so they went to visit. One medical director wanted to see how workflows happen in another clinic, so we linked the two medical directors to have those conversations. So a lot of linkages. We've had individuals with like EHRs that we're looking at how can we bring them together. Some are having more success than others with the specific EHR, so how can we bring them together? Increased collaboration and sharing across and within sites continued. So a few more. Better systems for using data to drive care and improvement. We see a lot of this working, utilizing our HIE-HIT contract with Comagine, and really building systems to pull data out. We have a few organizations that are still pulling data manually, which you can imagine is difficult. And so helping them figure out their system to get data at a push of a button. Some general challenges experienced is the organizational culture, especially relating to sharing. People don't want to share. We hold our cards close to our chest. We also don't want to be vulnerable. We don't want to share out what were challenges. But remember, that's all a part of quality improvement. Things are not perfect, and things will never be perfect, so there's always challenges and that, but we always don't want to share that out. Staffing, turnover, capacity. We heard about a lot of turnover today. Hopefully that will settle down. Getting the right data because of the lack of HIE, accurate coding, legislative barriers of getting that right data. Some of this has been great as they've organizations are trying to pull data. They realize the data going in is not great, or they're not able to capture it. So they're going back to those who are inputting data to change those systems to make sure that the data going in will reflect the data coming out, and we'll start to have good data. EMR accuracy, completeness, and transitions, working with other organizations, information sharing, getting changes to work well, and change plan terminology is confusing for some, and billing. So some challenges experienced. And I am way behind the agenda, and I apologize. Okay. I'm going to turn it over to Crystal. She's going to give us an opioid project update.
All right. Well, thank you for having me again today. I wanted to start out with the same slide that we looked at back in March when we did our last opioid update for the WPCC. And just a reminder that the ACH was given a toolkit with strategies in it. For the opioid project specifically, some of those strategies fell within primary care and behavioral health, things like opioid prescribing and MAT providers, and then some things fell outside of primary care and behavioral health, such as like having an education campaign or public awareness, stuff like that. And so we separated those two strategies. The opioid work group is really focusing on those things that are outside of primary care and behavioral health. Some of them incorporate or need to partner with primary care and behavioral health, but can't be done on their own. The others that were solely within primary care and behavioral health are incorporated into your change plan. And so you guys are already working on those. So I'm just going to focus on the stuff to the right. And I did add a little pink arrow down at the bottom, and that's because we want to make sure that these two things are connected, right? So the things that are happening in your change plan, in your clinics, is connected to the stuff that's happening out in the community. And Wendy and I are working on how do we make sure that those connections are happening and that you are aware of things that are happening within the community. So the work group developed a 2019 project plan, and I'm just going to give you an update on each of the items that are listed here. The first one was the Rapid Cycle Opioid Awards. This is an application that is opening every 6 months. It's for funding for up to 12 months, up to $10,000 to implement any kind of opioid project, as long as it has to do with prevention, treatment, overdose prevention, or recovery. And we recently awarded 5 organizations up to $10,000. They were all close to $10,000. And I put them up here so that you guys are aware of the organizations that are getting funding and what they're doing, and see it. They may fit into some of your change plans and see how you can connect there. So Chelan Douglas Community Action is hiring a AmeriCorps member focusing on opioid outreach and education. That will be happening in Chelan and Douglas counties. Grant County Health District is continuing to expand their syringe service program. And so they're expanding to new locations. The North Central ESD School Nurse Corps applied for funding to implement floor stock and in school districts in North Central Washington. There's a number of schools that are interested in that. And then North Valley Hospital is working on an education series, working with Tenasket High School, I believe, to do an assembly and a parent night and some stuff like that. And Oroville Cares Coalition up in Oroville is doing a project that's titled Pathways to Success, but it's a number of strategies that they are working on locally in Oroville. And that application actually came out of the Opioid Response Conference on March 15th. We held the Opioid Response Conference. It was a distributed conference that was held at 10 locations throughout North Central Washington at the same time, and they were each had a local facilitator to then facilitate a discussion after the keynote speakers. And we had 325 people participate in that, and 13 action plans were developed. We'll be doing this conference again in the fall. We're going to make it an annual event, but we, based on feedback, decided to make it a semi-annual event. So our next one will be in October. And this is also another great way for WPCC members to make those community linkages. We had a lot of community members and CBOs and stuff like that participate in this conference. This is just a map of where the 10 locations were, and we would like to expand this to have more locations, especially in Grant County in the fall. And I listed some of the project ideas. I'm not going to go through them because I know we are short on time, but they really fell into 2 categories, either school-based prevention work or information and resource sharing. So how do we know what resources are out there? There was a lot of comments that people there are a lot more resources than they know about. And then I mentioned that there were 13 community action plans developed. We gave them a form and a template, and basically it was to come up with a project idea, a champion, and immediate next steps. And so up here are listed the community action plans that were filled out at the conference, and then they each have a champion associated with them that's tasked with moving the work forward. And so I wanted to have this list for, wherever you're located, if there's something that seems interested and you want to reach out to them. If you don't have contact information, I'm happy to share that. And then I said our next steps, we are holding opioid response champion calls every month. So that was what the champions that were listed on the slide before that. Basically to share information, share what's happening if they're struggling with stuff. And we'll be holding this semi-annually. And a couple of early successes that were exciting is the Oroville Police Department adopted a Narcan policy that they didn't previously have. Mariah actually went up and presented to the City Council and trained them all on Narcan, and they adopted the policy. And then the Oroville Cares Coalition, who was the host in Oroville, applied for and received funding to implement their community action plan. One of the things that we identified was dental opioid prescribing as a concern. And so we offered a dental opioid prescribing workshop here locally in Wenatchee. On May 3rd, we had about 75 dentists and staff that attended, and they received continuing ed credits. And we were able to register about 10 dentists into the prescription monitoring program. Another piece that we're working on is school-based opioid prevention. We issued an RFP for up to $20,000. We're planning to award 3 awards, 1 per area. Chelan Douglas is an area, Okanagan and Grant County are each areas as well. There's 3 required components to this. It's to assess current school-based prevention efforts. What we learned when we were looking into how do we support school-based prevention is that there isn't really a good understanding of what's happening in all the districts across our region. And so if we don't know what's happening, it's really hard to figure out where you should prioritize and where you should invest your money. And so within this RFP, they'll be required to do that assessment and then develop a 2020 and 2021 project plan on school-based prevention, and specifically looking at how to support schools that don't currently have prevention efforts and bring them in. And then they're also tasked with financially or administratively supporting a minimum of one student-led prevention project. And we had 3 applications that will be awarded mid-July. We also have a Narcan training and distribution application that's open. I wanted to put this up here because WPCC members are eligible to apply for this. It's a small number. You're able to apply for up to 10 boxes of Narcan at the public interest purchase price of $75 a box. And we're doing it as a reimbursable application. So you would apply, we would tell you, yes, you get the funding allocated, but you have to then do the training and distribute the Narcan, and then we pay reimbursed for the cost of the Narcan. And that was because we didn't want a lot of people stockpiling Narcan. We wanted to make sure it was getting out there. This application's been open for a couple months, and we've had maybe applications. So we still have about $10,000, I think, available. So if you're interested in doing some Narcan distribution, this would be a great way to get some free Narcan. And then this is just a couple pictures. We did a Narcan training at the Central Washington Recovery Coalition on May 15th. That was well attended and fun. And then our last initiatives, we have some recovery initiatives. We had funding that was allocated towards recovery and worked with the Central Washington Recovery Coalition to identify some needs. And what we came up with was recovery coach training. And then kind of modeling what they did with the motivational interviewing, we want to offer a train the trainer so that we can build capacity locally, because we currently don't have any trainers for recovery coaches here. So that would really be able to reduce the cost if we have some local trainers. And then the same thing with Elevate Recovery Advocacy Training, which is an advocacy training for people in recovery to be able to tell their story and raise awareness. And then the last 2 things were to increase awareness and visibility through a recovery series. This would be interviewing or doing short, 2 to 3 minute videos of people in recovery, and supporting recovery events. The Chelan Douglas event is scheduled for September 28th, Hands Across the Bridge. And then if there are organizations in Grant County and Okanagan County that are interested in doing some kind of recovery awareness event in September, well, it doesn't have to be in September, that's just recovery month, but we'll have an application soon, but you could get in touch with me if you're interested in that. And our opioid work group meetings are open to everybody. You're welcome to attend, and we are voting at the governing board meeting, or it's being brought to the governing board to change our opioid work group meetings to just be quarterly via video conference. And then it does have a 50% attendance on a rolling calendar year required for voting, so you would have to attend at least 2 meetings a year. Our next meeting is August 16th, and I can send you the information. If you're interested in getting on the distribution list, let me know. Any questions?
Thanks, Crystal. We're just trying to bridge that gap between what we're doing in WPCC and what we're doing with the opioid work group. One thing that has become available just recently is AIMS Center has a contract with DBHR and ADAI. They have a grant through SAMHSA to provide OUD training. So if you're interested in any type of OUD type training for staff members, let me know. One, I have heard from a couple organizations seeking training. Apparently, providers receive training when they get waivers for MAT, but staff are never trained. And that's a workflow that has been changing in a lot of organizations. And this is a training that the AIM Center will offer, is training your staff in MAT, OUD usage, and how to, using motivational interviewing skills and other things, how to change your workflows to incorporate that into your practice. So if you're interested, reach out to me. They can be personalized trainings, and we work with AIM Center directly on that. Any questions? Anyone on the phone chat in or want to turn your microphone on? All right. Hearing none, I'll turn it over to Roger.
Thanks, Wendy. Good afternoon, everyone. A little bit sluggish there. All right, let's pick it up. It's great to be with you here again. Del, for your benefit, each month we've been doing a little module in these meetings focusing on leadership's role in supporting all of this work. And as Wendy said, all of the evidence base and leadership around change, quality improvement really points to leadership as being a critical success factor or a critical failure factor when things don't go well. We talked about team-based care. There's a lot of energy going on in that team-based care land right now. We've got over 120 some people participating. That's a lot of folks. A good example of leadership's role in supporting that, often you'll sign someone up, a team to go, and then that's the last they hear from you to the end and say, oh, how'd that thing go? And it's clearly a sign that this is just kind of another thing we're doing or checking off the box, as opposed to checking in regularly with each of the team or the team members. What are you learning from the process? How's this translating into improvement? What insights are you gaining? Also be forewarned, by opening Pandora's box about team, it starts to surface a lot of the culture issues in the organization and some of the challenges and some of the silos we often support in our own organizations. So they're likely to start to get into some dialogue around that, and that's part of our role in leadership, is to help navigate that, help them navigate, and also learn from it, learn how we can break down some of those barriers and silos. All of the work that's going on now is really supporting the culture pieces and moving towards how do we start to really do team-based care, not just be a team, but team-based care, where we're taking the work and really spreading it across the team and really managing to the top of our licensure. I remember working in Iowa on an improvement effort for one of the payers, and we had an organization with an early adopter physician who had been physician of the year, many of the year in the state, really high performer, great guy. And he sat down in this group that we're meeting and said, oh, we've got a great team. We've been working like a team for years. And I saw his two team members roll their eyes behind him. And he goes, right, ladies? And I'm like, oh, yeah, sure. And I stopped. I said, look, can we talk a little bit about, just notice a little body language with, well, Dr. Jim, we've worked together for 25 years. Yeah, we've been great. We're not really a team. And he just tells us what to do, and we just do it. There wasn't a real sense of team. It was a sense of loyalty around the physician or provider, not working as a team. And what we're suggesting in this new world, there's so much work to be done. It can't be all on the shoulders of one individual. It can't be the lead clinician in the organization. We have to take that work and spread it across. But to do that, you have to have the trust and the ability to really feel that sense of trust. And so that's what we have to try to help build in the organization. So today I'm going to be focusing on, let's see here, where's the arrows? We're going to be focusing on the measurement piece and continuing some of the dialogue that Wendy just mentioned relative to measurement. So last month we introduced the notion that on the portal now, data are available on the various measures that all of you have put in on your change plans. This diagram that's on the portal is what we call small multiples. It's a technique to show multiple measures in a single snapshot. It hopefully gives you much more of a balanced view of the measures as you walk in. It's really critical as leaders that you be aware of what are the measures that are now in the change plan. Some of you were those that directly put them in yourselves, so you're very tuned into them. In other cases, there may have been other people in the organization. But one of the questions is, how are you educating the broader audience? your other team members and leadership, others at a managerial level about these measures and how to use the measures in the organization. And you'll find that there'll be lots of challenges that in an initiative such as this, it's a really large scale with so many different things that you have in your change plan. Early on, there's probably a tendency to put things in and just kind of say, well, let's measure this and we'll do this and we'll do that. And now that the data is coming up, it's like, oh my gosh, you know, how are we actually going to do this now? How are we actually going to collect these measures? How are we going to really use these measures? And it starts to create a buzz. So, you know, be prepared for that as senior leaders and as leaders in the system and helping groups navigate this. With that, you will find that people will go through the stages of grief with the data. You know, the first stage is denial. That the data can't be right. This is just absolutely wrong. There's no way that, you know, our depression screening rate is 10% or colorectal screening rate is 5%. I mean, we're much better than that. And they may be right. In part of our role is to look at the data integrity. And we know that many organizations historically have been woefully lacking in terms of their proper coding of data. That then ends up getting captured in the claims-based systems. I know I see the payers shaking their heads. And when the data finally comes out, it's a mismatch from what you know and feel in clinical practice to what the data sets say you're doing. And that's part of our role in leadership, is to clean that up, to try to figure out how can we bring greater data integrity to get over that denial stage. We don't want to give people ammunition, because they'll do their own homework. They'll start to drill down and really look at their data elements and come back and say, oh, you're wrong here. I got proof on how many have done that. Some of it is wrong charting. Where in your record system are you putting the data? And so it's not being retrieved and aggregated in the way. And so this is a very healthy part of the journey, is to use the next few months in helping with that data integrity and cleaning up the data to be able to gain that confidence. Yes? So the question is, how much of it is the lack of standardized processes? A lot. If you're able to standardize the workflow and standardize the process and be very clear on what data elements go where in the chart, what is the process for getting that, who does that data entry, and make that consistent, your data integrity increases dramatically. So part of this journey, and we've talked about process mapping was a tool early on that we've been teaching many organizations. That's where you get the process mapping. Many organizations will take the measures that they're held accountable for, externally and internally, and for each of those measures have a very clear data process map. This is where the data comes from, how we get in the system, and they standardize the workflow so that they're able to improve the measure. So you'll often find, just by working on your data integrity without doing any other improvement work, you'll often find that you'll get a bump in your performance of your measures just by cleaning up the data process in the journey. Does that help address? So you'll once you do clean it up and there is integrity, then there's the anger stage where they're going to be really mad. Well, you know, gee, well, you know, it's not my fault. And I think it's really important to remember that historically in healthcare, it's not too long ago where data were used to really beat up on care teams, especially physicians. Under the old peer review days, several decades ago, data was used to look for the outlier, to punish that person, get them out of the system. They're not practicing according to proper practice. And so we've beat people up with data, and now we've come along, switched the rules of the game, and say, oh, no, data's your friend, and we're going to use this to all work together and be happy. And they're like, yeah, right. I'll see it when I believe it. So there's still a lot of fear in the environment. In many organizations, we're hammering on our teams for clinical productivity. You got to see more patients. Got to get on that treadmill. So we're using that data to negatively reinforce, and now we're coming along and saying, oh, this data is our friend. So be very cognizant of that as we move through. And you'll see the bargaining phase. We'll start to say, well, what if we only collect a subset of the data, or just a target that we're really working on? And then a little bit of depression when they realize this is reality. And that's where, as leaders, as we hit this depression stage, it's linking them to the change plans, the tools, the methods, the resources on what to do about that performance. How can we use this data to really improve? And they'll finally get to the point where there's acceptance. This journey takes months. It's not something that generally happens overnight. You have to really build that confidence in your data set as you're moving forward with the process. So I'm going to just do a quick reminder of the different types of data. This is aimed for you, to remind you on coaching your teams and your organization. Some of you could be up here preaching about data and very, very tuned into all this. So remember, there are data for accountability. So the Healthcare Authority has a set of measures, and they have this grant that they're holding WPCC accountable to. And so those are accountability measures. Where possible, you'd like accountability measures to line and cascade all the way through the system, but that's not always the case. Sometimes an accountability measure may not be the right measure you need at the point of service to drive improvement. So be thinking through and don't just jump on the bandwagon relative to the measures. There are measures for quality control. This is an area where we have been woefully inadequate in healthcare. We tend to do improvement projects and use data to improve, but we don't necessarily put the long-term quality control at the point of service, so that you can go in and at each care process see someone who's responsible for measuring that and tracking it. So I'll give you an example. You'll get patient complaints about waiting in your clinic. Could be in an emergency room, could be in behavioral health, could be anywhere. You get all these complaints about waiting, and all of a sudden, months later, you see your CAP scores negative, and oh, we need a quality improvement project. Now we have a quality improvement project, and we put a team on it, and they work on trying to improve that. But we don't necessarily put in the key metrics at the point of service that allow you to drive that indicator, that quality control. So cycle time in the clinic. If waiting is an issue, how are we measuring cycle time? And doing that at the clinic level, where they're own that, where they're responsible for it. You could roll that measure up, but the most important thing is those people that real time are working on cycle time, there are things they can do in the middle of a clinic day to adjust things, to adjust cycle time if they're paying attention to it. But if they're not measuring it, then they're not going to manage it. So be thinking, but remember quality control. And as you do various improvement projects throughout the course of the next few years, always have in your mind in leadership, what's the quality control mechanism that's going to stay in place, that's delegated down to the point of service for those that are running that process, and is in place long term. We're ensuring that reliable integrity of that system. For those of you in the hospital arena, Joint Commission, and for those that are Joint Commission accredited, a big focus on high reliability organizations. That's all about the quality control piece. It's really about building that quality control and reliable systems. There's quality improvement measures, and some of those measures tied to individual PDSA cycles. They could be very short term around a PDSA cycle, or they could be longer term based on the project, but remembering that the quality improvement measures may be different than some of these other measures in place. And then there are quality planning measures. There may be measures that you use to design as part of your quality planning system. And I'll show you an example of that in a second. The types of measures, keep in mind that there are process measures such as cycle time. There are outcome measures, so hemoglobin A1C levels for patients would be an outcome measure. There could be structural measures, which could be a policy. That you need to have a policy in place for a particular thing, or a process map in place for a particular thing. And then there can be milestone measures. We're going to make sure that we have a certain thing by X date. And once we achieve that, then we're going to get accredited by PCMH by January 30th. By NCQA. That's a milestone, right? That's a particular date and time that you're trying to reach, and that's just a measure of progress. Those are different types of measures. We also like to see, where possible, balancing measures. So a lot of organizations will go through some tough times and put a lot of emphasis on cost control and the finances, to the point where they start cutting into the meat and the bone, and you see turnover going up and you see patient satisfaction going down. So you'd like to have some of those balancing measures in the organization that you are able to see the whole picture. That's why those small multiples can be very valuable. You can see a balancing measure at the same time you're working on something else to make sure things aren't getting out of whack, and keeping that in mind. So be thinking about things as you're working with a team and they say, oh, we'd like to collect something on this. Is there a balancing measure that we can make sure that we're not doing something that is putting things out of whack? And then lastly, there's the concept of leading and lagging indicators. So lagging indicator is something that may take some time before you see the indicator change. So for those of you that are doing CAPS, the patient surveys, CAPS for the patient surveys of perceived quality and access to care, you may only do that once a year. You do it every 6 months. So if you're making a change, you might not see a change for 6 months to a year. Whereas a leading indicator is something you might see this month. You could see on a regular basis. So if you say, let's work on overall improving the quality of life for people with depression. Any of you are working on depression, if you have an overall aggregate indicator, you might not see that aggregate indicator change for a while. But if your screening rate's really low, then maybe screening is your leading indicator. Number of people screened on a regular basis. And as you get more people screened, then you can move up to the next step on what's another indicator that'll help us see that all of this work we're doing is actually translating into improvement. So be thinking about leading and lagging indicators. Data, in the end, needs to be visualized. So we showed those run charts in the small multiples. On the left-hand screen is something called a radar chart. I bring this up because CMS is increasingly using the radar charts for some of their projects from an accountability perspective to see progress towards goal. So in a radar chart, that outer, it could be the outer rim or it could be the inner rim, depending how you set it up. But the outer rim in this case would be the goal. And so you see that there on this graph, there are 6 indicators. You don't even need to know what the indicators are. You can just visually see where the line is. If it's towards the center, that's 0 progress to goal. And towards the outside is 100% achievement of goal. So by looking at a set of goals, you can take a quick snapshot and see how is this particular entity or organization moving towards the goals. Now, what would be the downside of a radar chart like that? Any downside? This is the participation portion of the program. What's the downside of a radar chart like that? Any hypotheses? It's pretty. Lots of different colors.
One would be potentially, they appear to be valued equally.
Yeah, so there's no weighting of the values. It just shows you progress to goal, and it's a point in time. So last month you might have actually had a higher performance, and this month you're lower, right? And so you're not really seeing the trend. Is the trend going in any particular direction? That's why we want to use something on the right, which is what's known as a run chart. All of you are familiar, I think, with run charts. You'll see this one is a run chart. This is actually a run chart from work we did at Hopkins years ago. And this is an annotated run chart where you see the different PDSA cycles that they tested and how it correlated with some change in the data over time. So this is called an annotated run chart. So this is great for quality improvement and for learning in an organization. If you have teams working on a project and they're making changes, as a leader, ask them, what changes are you making and how does it connect to your data? Where are you seeing the data start to move as part of your overall effort? Early on, I showed this graph. This is an adaptation of Duran's trilogy in quality. And you'll see on the left-hand side, it says quality planning. This is where we have data for quality planning. Ideally, you'd like to get feedback from your customers. Could be the payers, could be your patients and families, could be your employees, whoever you identify as your customers, and finding out what's the most important thing to them, what attribute is most important thing to them, and translate that into a key quality characteristic, KQC. Payers, in many ways, have already defined that through their HEDIS measures. They're being held accountable by CMS on a certain set of HEDIS measures, and they're transcending that on to all of you in the form of accountability in terms of measures. So that can be predefined. In other areas, you have to do a little work and gather that information and come up with something that is a way to measure how are you doing in terms of progress on meeting your customers' needs and expectations. So I'll get back to my issue of patients. If you have low patients' CAP scores, and you start to talk to the patients and do focus groups or informally talking to them, say, you know, what really presses you most or is the most important thing? They may say ER, time to triage in the ER. And you could talk to the patients and say, well, what would be a reasonable time? If that's the most important thing, and you're coming to our organization and it's in our ER, how quickly you get triaged, then we can measure that, and that becomes our indicator. And let's say that your patients say 10 minutes is the average amount that we find would be acceptable. I want to be triaged within 10 minutes of getting there. Okay, well, we can measure that, and we can start to track it. And then we can put quality control. How are we doing? What % of our patients are getting in and triaged within 10 minutes? Well, you may find out that 90% of the time you don't do it within 10 minutes. So 90% of the time you're failing your customer, you're failing your patient. And that gives you some insight. Well, maybe we need to change that. So I've seen emergency rooms that triage before they register the patient. I'll have someone immediately do a quick triage and get to the patient and say, okay, you're stable. We're going to now get you registered and into the system. And I'm going to have Molly or John here help you with that registration. Because they recognize that's the most important thing for the patient. They wouldn't have changed their system unless they measured to see what % of the time they were not in compliance. So that's a quality planning measure put into a quality control measure. And then you can say, well, what can we do to change it? That's where your change packages get into. The change packages are the ideas, the concepts with some evidence base that they can help change the system. Now, one of the things to be looking for, common cause versus special cause variation. All of you probably have been through the quality training to some degree about common cause and special cause. So common cause variation is based on the design of the system, how all of the variables come to play on a daily basis, and it's inherent in every event. Every process has common cause variation. Special cause variation is usually due to something outside of the process itself that's influencing the system. And it's something that often generates an immediate reaction from the organization. A board member complains, or you have a sentinel event. And all of a sudden we're jumping in, and the way we go about changing things is we try to change the system when often the event is outside of the system itself. And what we end up doing is tampering. We end up messing up the system. Yet we spend relatively little time on the common cause variation. We're constantly fighting fires on that special cause. So one of the lessons is the more you can understand the variation and start to park those things. So let me give you an example of getting a patient complaint that goes to a board member. Mrs. Jones was in your facility and got ranch dressing instead of olive and vinegar dressing on November 9th last year. What are you going to do about it? And all of a sudden, we're pulling in the food service manager or the catering people and, having these lengthy discussions and ready to change the process when that's just a special one-of event that is outside of the norm system. 99.99% of the time, you get it right. You don't need to be changing your whole system then. Unfortunately, we in leadership, I've done it in my role in leadership, others, we are constantly tampering, not understanding these special causes versus these common causes. So be thinking about that as people are coming to you with a request to make changes to your systems. What is it in response to? Is it in response to a common cause that's going to help everything? Or is it due to a special cause? And maybe we need to really understand it a little bit more as we move forward. So we want to track the data over time and see the trends where possible. We want to understand those special causes and those common causes. There are run chart rules, and part of what we're doing is building capacity with your team. So this is happening in the QI affinity group that we're hosting. This is part of the QI training that we're doing. It's how to look at the run charts and understand the rules. There are handouts available and information. The special cause rules, those are the translation of those rules to understand special cause. Now, when you make changes, when you're doing PDSA cycles on a process, you're introducing special cause. That's a good special cause. You're trying to improve the system, right? What you don't want are the random special causes. So you want to be able to study the system, intervene, and then see if your process is having an impact. So let's translate theory into practice. These are needle sticks in a hospital per 1,000 patient days over a multi-year period. Do you see any special cause in there? Any special cause? See that no explanation for that peak? July of 87? All right. So this organization was a major HIV AIDS center, and needle sticks of employees were a huge issue, huge issue. Walking down the hallway one day, there's a nurse crying in the hallway. I stopped this nurse and said, Jerry, what's wrong? I can't take it. I'm on 5 needle stick committees. I said, 5 needle sticks, what do you mean? You're from a 5th meeting in 5 months in a row? No, I'm on 5 different committees. So the organization's response was not to study the data, never trended the data over time. Every month they had a chart of needle sticks, and they had 5 different committees working on this process. So well, has anybody looked at the data over time? And so we looked at the data over time. You see that over time there's all this random cause variation. None of those committees have been doing anything for 2 or 3 years in a row, no impact. Yet in July of 87, boom, this spike. What would have caused that spike in July of 87? Any guess? More testing? Yeah, absolutely. The CDC put out a national announcement that you need to do more routine screening and testing, and all of a sudden that there's a lot of needle sticks that are happening. You need to do sentinel reporting of needle sticks, and all these needle sticks that weren't being reported suddenly spike up. This is called the Hawthorne effect. Now, spiked up all of a sudden because an email went out to everybody, and then went right back to its normal variation. Right. So leadership, we want to understand all that craziness. We want to get in there and say, wow, what are we learning from this? But how do we avoid those special spikes that are just tampering? And let's really work on controlling that data. So here's a case study of starting to break down data so that it's manageable. And I think one of the things you'll hear from the staff is this is just overwhelming. You're asking me to go out and affect these people's lives, and there's too many of them. Their lives are so complicated, it's just impossible to manage all of this. So we want to be able to make it much more manageable as we move forward. So this is a case study that we worked with a few years back as part of a national program from ONC, the Office of the National Coordinator for HIT. And in this program, they were trying to support the national goal of reducing heart disease. Okay? That had been translated to Million Hearts campaign that many of you have participated in over the last few years. That Million Hearts campaign had part of their funding went to the ONC Beacon communities. There were, I think, 19 communities around the country that were funded to integrate technology and use it to drive improvement across the community. And so they said, okay, let's take 6 organizations out of that pilot. And let's get them to work on reducing heart disease. And what could they do? Well, they could work on improving LDL control. And let's do it over a very short period of time, 16 weeks. Let's not take a year or 2 years. Let's do it over a short period of time. So when you hear us talk about sprints as a learning model, this is a type of sprint. Do it over a short period of time, pull us some activity, see what you can do. One organization said, okay, I'll work on that for 16 weeks. We can do that. We'll put a team on it. We have to meet weekly and really drive improvement into daily work. So they began working on it, and then they started looking at their data. They came up with their change package, or their theory of change, the ability to break problems down into their sub-processes. So we realized we can't tackle the whole elephant, so let's look at sub-processes. That if we make overarching system changes, it would likely affect all of the data elements. Data is going to be critical to driving the improvement, and anybody can improve. So they started segmenting their data. Okay, so LDL control, number of patients that have diabetes, that have their lipids under control, and are on a statin, one of the key indicators. Let's take a look at that, and then let's look at our data. So the first thing they did is, out of all the patients we have, how many have diabetes? So that's a subset, be anywhere from 6 to 20 to 30%. So out of that 30% of people, how many were really at risk? Diabetes is a much smaller number. Now you're getting into the couple hundred. And out of those, how many have not been in for screening? The only issue is they haven't come into the clinic because they haven't been in for screening. Lo and behold, found a large bucket of patients just haven't come in because they feel well, they're okay, but they haven't had their annual screen. So that's something we can do. We can manage that. We can go out there and bring those patients in and drive improvement. So each of these represent a different decision tree of what can we do, break down the data further and further and further. And when it gets down to the bottom, there's a bucket there for patients that are just not in control, that are very brittle, difficult diabetics. And it turned out in these organizations a very small number. Those ones had to really be micromanaged in terms of their medication control. But most of the rest of the stuff was about our processes. It's about how are we collecting the data and where were we putting it that is missing in the chart. It was about patients who haven't been into the clinic since the last data point and needed to come back in for a rescreening. Found out through this process that patients were being called in and being screened and said, okay, we need to get a lab value, but you need to go across the street to get your blood tested, and then the results will be sent back to us. Patients walked out the door and went right home because of the design of their system. So when they moved the lab collection to the point of service, their rates improved dramatically. So the point of this whole piece here is by taking a really large and unmanageable number of patients and saying, let's really understand it and start to segment the data. Let's start to break it down into those manageable pieces that we can work on. Then let's just see how we could do that. At a clinic level, what that means is let's not work on the whole population. What about the patients coming in this week? Let's look at Monday. How many of our patients are coming in? How many would be at risk? And for those patients, let's make sure we get them, get their data, get their labs, and if they need to be on a med, let's get them on a med and let them not slip through our cracks because of our processes. That led to dramatic improvements. And so you see over time, the number of the patients that had not been screened or not in control, these are small numbers, manageable by one panel of patients, but able to improve it over time. So all of this is about being clear on your measures. What are you measuring? Helping the staff understand the measures. If there's pushback on the data integrity, saying, that's great, maybe the data is wrong. Let's go in and look at it. And is it a coding issue? Is it a data entry issue? We're putting data in the wrong place in your record. Let's help them understand. Don't immediately push back. Guide them through the journey. Once you get that data integrity, then help them move up to the higher levels of what can we do to trend the data, understand it, and then use it to improve. Let's bring that back to the work here that you're going to be doing over the next few months. You may remember we had a dialogue. You may remember we had a dialogue about what condition might we work on as a group. And we talked about asthma, and the data didn't really support asthma. And what came back from all of you is that there are opportunities in depression. And most of the organizations are working on depression, and a lot of the organizations are working on diabetes care, and that might lend themselves to a collaborative effort across the WPCC over the next few months. So we're heading towards the fall, and this is the data from the, Caroline, this is from the Healthcare Authority data, is that correct? So this is the Healthcare Authority data, and I know this is relatively small, but if you look to the right far-hand column, you'll see that there are, some of those are very small numbers. A population of 2 across the WPCC, if you changed, that would improve you and move you to a different quartile in your overall data. Well, if you're getting reimbursed based on your performance and improvement, then trying to move those small numbers is not a gargantuan challenge. It just means some collaboration and figure out. That might be one organization being able to move the measure for the whole group. So we need to really understand what are those opportunities and why. And if we could really start to play with the dials together, we could move all those indicators up and really show some dramatic progress as a group. What we're proposing is that in the fall, what we'd like to do is start to work on 2 conditions as we move into the population level work. If we could work on depression and diabetes as a group and leverage the collective resources of the organizations, but also of your community resources. There are community-based organizations that are also working on diabetes, also working on depression. So how can we engage some of them? Some of the work on opioid management, for example, might have a crossover with depression and managing the underlying depression that's leading to the substance abuse. So those entities that are out in the community, how can we leverage all of that to really drive improvement across the environment? These are the common measures around depression or these are the overall common measures that people are most collecting in the collaborative that Wendy showed earlier. So if you look at all the change plans, you'll see that almost everybody is doing depression screen and follow-up as a measure. You'll notice diabetes is not on there, interestingly enough. Yet that was the highest one, and most of you said, if we're going to work on a clinical condition, that one resonates the most with us in terms of our effort. And I know for the FQHCs that that's a core measure that they're working on for HRSA. Anyway. So what we want to do, and we're not going to resolve this today, but hopefully have a little bit of dialogue, we'd like to see if there's one or two measures in diabetes management that we could all agree on as a common measure across the board that we could track as a WPCC as we move into the fall October meeting. What we'd like to do is some homework between now and then to see what data are available in the environment, what data we might have available from the payers, from the healthcare authority, from any sources, similar to what we tried to do with asthma, and see what that tells us about the prevalence of diabetes in the region. And then as you look at your change plans, start to align the work as we do the population level work in the land, and we get together face-to-face, we're going to be focusing on content to share with you on how to improve the health of the population. And what we would like to do is use depression management and diabetes as the case studies, that it's relevant to what you're working on as entities, and then move that forward. So we'll be asking you to be thinking about what diabetes measures are most relevant to you. What are the ones that you think are being most pertinent as we move forward? And we'll have some dialogue about this at the next meeting and the following meeting. There are diabetes measures, and then you already have some depression measures, depression screening and follow-up, and then mental health service penetration for depression are two measures you're already collecting now. So that's something that's a lot more commonality around that, but we can, at least the depression screening measure is one that most of you that are working on this seem to be collecting, and we can help resonate on that. So I'm going to open up for dialogue here in a second. We're going to be continuing from a learning perspective, working on the team-based care land that most of the organizations are participating one way or another. As I said, we have 125 to 130 people on the webcast, so it's a lot of engagement on that. We're going to be doing a webcast on access in September. The focus of that is going to be really looking at what are the levers you can change as an organization to influence access, and some examples of how to do that. And then as we move into the October meeting and future webcasts and calls that we have, we'll be continuing to have access as a track that we'll be working on. Recognize that many of you have already worked on access. Others are just beginning and want to start working on access. Some of you have real lessons from your work on access that hopefully we can tease out and identify some of the exemplars and share across the environment. We'll be working on finalizing measures around diabetes care and depression, engaging all of you over the next couple of months so that you're in agreement with those measures, so that as we go into that fall face-to-face meeting, we'll have some data and information to be able to share with you, and then start to see how we can move those dials over the ensuing months. So let me stop there and see what questions you have, and then let's talk about your thoughts on some common measures of the ability to work together on depression and diabetes. So any questions to begin with? Any of that make sense? Any questions about your role in terms of supporting or helping to accelerate it with the teams, either on team-based care or relative to the measures, your change packages?
The timeline for finalizing the measures is sometime between October and October.
Between now and October, yeah. We'll be working with you so that as we go in there, we'll all be clear. So the teams that are participating, we're going to say, here are the measures and why, and that there's been a consensus that your leadership's bought into them. It's not some wacky thing that we're imposing on you, but that the leadership really thinks these are the important things, and that you're going to be supported as you move forward in helping accelerate that. Hopefully this aligns with your aims. This is what you told us were the most important things to work on for your own projects, whether it's for your physicians or clinicians that are working on their own personal improvement projects, for their recertification or for your external accountability, whether that's to HRSA or to payers or to others, that this aligns with that work and help accelerate, certainly in alignment with what the WPCC had suggested early on and what the state is encouraging to do, so that ideally this will cascade all the way down and we'll be able to really show how we can move the needle on a couple of these pieces. Other questions?
Roger, can I just say that diabetes and depression was chosen by this group on that learning activity survey we put out in March. And just to note that we are one of the top performing ACHs in diabetes, but that is still something you guys wanted to work on because you're working on it internally.
Any other questions? And Wendy, I'll turn it back over to you.
Thanks, Roger. All right, we have about 10 minutes left. Let's go for a quick round robin. Let's hear about a success that you had during your first half of your year in the work that you're doing with the WPCC. Who would like to start? Thanks, Deb.
I would like to report that a local Wenatchee behavioral health organization reached out to Action Health Partners to talk about a partnership with us and them around diabetes self-management program. So we're working on moving forward with, actually, I believe we're most of the way through a diabetes self-management workshop for case managers to understand what exactly the program is, and then the eventual goal will be to get a case manager and a client, patient of their organization to become lay leaders so they can do the diabetes self-management in their own agency under our diabetes self-management license.
That's fantastic. Anyone else? Success they'd like to share? Anyone on the phone? You're welcome to chime in as well or chat in.
So several months ago, after quite a bit of discussion, Columbia Valley Community Health and Catholic Charities partnered to make sure that some of the clients of Catholic Charities had better access to primary care. We now have a provider from our East Wenatchee location who goes over there. I believe, Blake, it's 2 days every week, and it looks like somewhere down the road we'll need to up that a bit because he's now pretty active on the days when he's there.
And just to piggyback on that, Chris from Catholic Charities chimed in because I know the team worked with your provider. They implemented a whole person care data set used for stratification of our patient population. It was presented by Catholic Charities and the University of Washington Ames Center at the Washington State Behavioral Health Conference in Vancouver. And that data set, Jamie will present to the WPCC on that soon. To learn more about it, but that was born out of the LAN that we did last year. Anyone else? I've read the reports. I know there are a lot of successes.
Yeah, I think it's relevant to mention Dave Cole.
Microphone.
You guys probably know Dave Coldy's moving on. But he, one of the things he did was utilize an open access model and transform the scheduling process for one of our primary care clinics. Got buy-in from everybody and the transition. So I think it may be too early to really know what it has done for access. I know it's one of those learning processes, but I think he's very proud that he achieved that while working here.
Great.
Yeah.
Hopefully you'll be able to report out on successes of it.
You bet.
Anyone else? I will say Confluence just rolled out, finally implemented your opioid prescribing also, didn't you?
Yeah, I guess so.
Yes, I think you guys had a soft rollout on your opioid prescribing guidelines, am I right?
Yeah, so are you good? So we have a few elements of that, and I'm sorry I'm not totally up to speed where we're at with that, but we have, for example, worked with our EMR to implement an automatic flagging of PMP has been interrogated, and to allow you to do that from within the EMR, and then also an MED calculation that sort of gives you an alert if you're high. So a couple things. It's not perfect, but it's something that didn't exist before. Yeah.
Excellent. Thank you.
One more thing we've done, at least in the behavioral health part of Confluence Health, is really working with patients who are on atypical antipsychotics to make sure they're getting their metabolic monitoring screening on a regular basis. And we've seen quite a bit of improvement. Haven't quite hit our target yet, but it's been quite a bit of a big improvement so far.
Great. That was born out of that LAN also last year, right? When we talk about the impact of the learning activities, this is just some of the impact of them. Shoshana, are you still on the line that you could speak about your impanelment? Sorry, I'm putting you on the spot there. Maybe she stepped away. Anyone else? Do you want to talk about your collaboration with primary care and asthma? Okay, Children's Home Society.
Well, that we were going to help with children who had a diagnosis of asthma. And so we wanted to collaborate with their pediatrician to say we want to reinforce confidence in their treatment plan. So, because what we had is overutilization of the ED for asthma attacks. But what we found is that we were breaking down in getting our treatment plan and then having the pediatrician return something to us that was usable to connect with the parents. So what was happening is a lot of parents would say, oh, you have asthma, just wait and see, I'll come home from work and it'll be fine. We'll just eat something. They didn't understand the nature of asthma and that it just gets worse and worse up in the emergency room. So we worked on that internally, developed it very specifically. And then our first time out of the gate is we were able to collaborate with a pediatrician. We sent over our treatment plan and they signed off on it and sent it back. And we were hoping for an asthma treatment plan, but they sent ours back. So we've been working on that a little bit more and we're having greater success. But I would say that we're only able to identify a few clients who have asthma within our population. So one of the things that we've been doing instead of that, so this is kind of one of those stories where you're like, yeah, that didn't work. We're going to have to try this over here. So I hate being the one who has that story. But one of the things that we've been needing to do with pediatricians and outside providers is we have what's called wraparound. So we have a WISE team that works with a lot of clients who need wraparound. So they're very high needs, very intensive. In collaborating with these particular kids, is a lot of times our therapists are outside of Children's Home Society. So that's awesome, but we have some breakdown in communication because we don't know what the therapist goals are off-site, and the communication between the WISE team can be difficult. So we actually hired on a case manager specifically to bridge that gap. So we're kind of excited about that, how that's happening. That person was actually supposed to be here today, but there was a child family team meeting with just such a scenario. So this is kind of our first foray into that, with having a case manager on site with a therapist who does not work in-house and our WISE team. So getting them collaborating. That's kind of my example of, oops, this wasn't quite working like we hoped it would, but over here we have some delicious stuff happening.
Thanks, Holly. I think it's a great example of a PDSA. And it's what we all go through because we try something, we hypothesize, we think it's going to work, and when you actually get down to do it, it doesn't, and you've got to figure out something else. And that's just the nature of business. So thanks for sharing. We are actually at 12:45. Shoshana was trying to talk, but she was on mute, so I let her off the hook this time. But thanks, everybody, for coming, and we'll see you next month.